me out. Go ahead.
All right, so I did not do neuro this week. I'm sorry, guys. I did an ortho case. So title of my article is Altered Scapular Orientation During Arm Elevation in Patients with Insidious Onset Neck Pain and Whiplash Associated Disorder. So as we know, coordination of traps and serratus anterior and the extensibility of levator, pecs, and rhomboids can lead to changes in scapular orientation and then therefore lead to detrimental loads on the cervical spine. And they can then create or sustain mechanical dysfunction, which can increase the recurrence of neck pain. So the purpose of this article was to investigate whether there was a pattern of altered scapular orientation during arm elevation in patients with insidious onset neck pain or whiplash. Divided into 3 groups: insidious onset neck pain, whiplash grade 2, and a control group. They were recruited from a sample of convenience from a local PT clinic. They were all between 18 and 55 years old, with at least a 10 out of 50 on the NDI for at least 6 months. All were right-hand dominant. They were excluded if they had any prior shoulder pathology, history of head or spine fractures, or any serious psychological pathology. They placed 3 electronic sensors on the sternum, the acromion on the posterior aspect of the humerus. Patients were seated on a chair with the sacrum flat against the wall, and then they raised, there's a wall on the posterior aspect of their arm, and then they would raise the upper extremity in the scapular plane. Patients would raise and lower at a rate of about 60 beats per minute and tested bilaterally. The results showed that the whiplash group had increased elevation when compared to both the controls and the idiopathic pain group, which was thought to be due to insufficiency of serratus and lower trap, or reduced middle trap activation to limit upper trap activation. And that kind of has been shown in the research. Research has shown that those with whiplash associated disorder had increased and longer activation of trapezius, especially upper trap. Also, both the whiplash and idiopathic pain groups had reduced posterior tilt, with whiplash having even less so, thought to be due to short pecs or increased activity of levator scap or rhomboids. And then both whiplash and idiopathic groups and control had reduced clavicle retraction on the dominant side, which is very common. It's due to the shortness of pecs. So the theory is that pain in the cervical spine leads to altered scap muscle activity as a result of a feed-forward response to minimize activation of painful muscles or to compensate for inhibited muscles, or it's due to excessive contraction, potentially of upper trapezius and levator, which attach to the upper cervical spine and the skull, to also reduce compression on the brachial plexus, which could be painful. And also, that's pretty much it. Any questions?
Remind me what NDI was.
Neck Disability Index. It's a disability score, 0 to, I think, 50. Under 10 is like no disability, and anything above is a medium, mild, whatever. So.
Thank you.
You're welcome.
Sorry, so it was the whiplash group that had the most altered scapular mechanics?
Yeah, and they think that's due to guarding mechanisms just to protect the potentially vulnerable. And it's interesting, they only see increased activation in chronic groups and not acute groups. So they think that's just due to guarding mechanisms to prevent further irritation of the plexus, potentially, or overactivation.
So they measured altered scapular mechanics by measuring arm elevation?
Yeah. Yeah, so they just had, it's 3 electronic sensors. I've only seen it once, but 3 electronic sensors: sternum, acromion on the superior part, I believe, and then also on the posterior aspect above the epicondyles. It's got really good sensitivity. I think and reliability. I want to say it's usually off by 0.15 degrees or something like that. It's something really minuscule.
What does that measure, like the angle or?
Yeah, the angle and the rotations of different planes. So yeah.
Okay. Cool. Did the article give any like recommendations as far as treatment and stuff?
It kind of goes with what we think that you should be, if you have a neck injury, also look at the shoulder, because you can treat both and you might find relief of symptoms. So just look. I mean, it's worth a look at least.
Cool.
Yeah. So how would you prevent guarding, or like try to decrease guarding and try to obviously attack all the muscles like we were saying, like mid trap, low trap, serratus? What would a quick solution be to try to decrease guarding?
I mean, anything relaxation. I mean, and also I think it's patient dependent. Some people don't like having heat on their neck. Some people don't like soft tissue work. So just finding what is relaxing to your patient, and it might be a little trial and error, but, and then just working on some weaknesses that they have, especially in the shoulder or activation patterns, just seeing if you can get the right biomechanics.
E-stim, upper trap?
I hate E-stim.
You can also do the taping method we talked about just for the cueing.
Yeah, I mean, I love to just like get on somebody's scap, posteriorly tilt, retract it, and it can make a huge difference in somebody.
Yeah.
So for the muscles that they were highlighting, like you'd mentioned, like upper trap and levator, did they do that based on, I might have missed it. Was that based on like observation or palpation or like what?
So that was based on previous research that was kind of what they hypothesized based on what they saw in their study. So yeah, ideally in this study, they would have looked at also activation patterns at the same time as they were measuring. So, you know, it's not a perfect study, but you get an idea at least. Also,
sorry, go ahead.
I was gonna say also my work forced me to read this article. So
I'm wondering if like is it like the chicken before the egg? Like, did they have poor scapular tracking prior to the whiplash injury, which just like predisposed them to having increased neck pain, or was it the whiplash injury that?
Well, obviously, it's not a prospective study?
Yeah.
So
that'd be an interesting one to look at, though.
Yeah.
So definitely, it's more causal or like correlation rather than causal.
Mm-hmm.
All right, buddy, you're gonna get in a car crash. We'll schedule that for 5:52.
Yeah, I guess it doesn't really work, does it?
All right. Any more questions for Taylor? That was good questions. Cool. I have Rebecca next. Are you prepared, Rebecca? Or
I went over everything. Okay,
good?
So my article was on neurodynamics. So basically, they drew it was a systematic review, and there was 5 to 6 conclusions. So the first one is that typical, when you do your nerve testing for median, ulnar, etc., it doesn't always, sorry. Okay, so it does not always
Rebecca, we can't hear you.
These technical difficulties.
Okay, can you hear me better now?
Yes, absolutely.
Okay.
We lost you.
So aerodynamic tests, they don't fit with the exact distribution of the nerves. And in addition, they found that even if you get a negative on one of the tests, it doesn't mean that the neurodynamics aren't necessarily impaired. So you can still get a negative upper limb tension test, and there could still be problems with the gliding of the nerve. And so if you already have a suspicion that one of your patients, it sounds like and smells like there might be an issue in the nerve, even if your ULTT isn't positive, I would just give them some gliding to treat them anyway. In addition, they also found that typically with
It's not me, right?
No, you're good.
Stable connections only.
I'm counting. Rebecca,
what?
past 20-ish seconds was unheard.
Oh, wait, did you hear the part about the negative ULTT?
Right about then, yeah, it was if you have a negative ULTT, they might still have neurodynamic issues. You might want to give them some gliding anyways.
Okay, I'm sorry, I'm ruining the recording. Let me try it with headphones.
Sure, sure. Whatever you think is best.
Okay, 1 second.
Please stand by for technical difficulties, viewers. This is our first recording.
Is this better? Can you hear me better now?
I mean, we could hear you, but it just goes like in and out every once in a while.
Oh, hold on. I'm just gonna walk inside the house and you'll be able to hear me better.
Right.
Probably. 1 moment, please. You could do this. Okay. All right. So neurodynamics. Basically, so they found that if you're gliding the nerve and you're doing like a treatment, there's primarily only research for the medium nerve that shows that improves like how well the nerve is moving. However, there's not as much research for the ulnar and the radial nerve. And they found that not only does it help improve like nerve gliding, like by doing those treatments, but it also produces analgesic effects. So it's been found to reduce like the intraneural like edema in the area and things like that. So it can help like in other ways besides just the mechanical movement of the nerve. And then they also found that typically with the nerve testing, it primarily tests like the larger fibers. And so it doesn't really look at like small fibers for the nerves. And so for those, they mentioned that you have to test it like with the temperature and I think pinprick. So more specific than just soft touch. And in addition, I'm checking my notes real quick. Okay, so they also found that okay, so even if you have increased nerve mechanosensitivity, it doesn't necessarily mean there's going to be neuropathic pain. So someone can be more sensitive, like with the ULTT, but they may not have any like nerve pain to go along with it. And they also found that even if there are central signs and like central neurogenic like effects in play, you should also still treat the peripheral trigger. So the peripheral trigger could be like, oh, you have a really tight and high tone in your pronator teres or something like that. Like even if like it sounds central, like you can still treat it through addressing the peripheral mechanisms. And so that was I believe that was all of their conclusions for it. Yeah, and then that was all. I'm sorry if it was hard to understand.
Was this
I apologize.
Was this like what kind of paper was this? Was this like a systematic review or like a?
Correct.
Yeah. Oh, was it? Sorry, I missed that.
Yes.
I have a comment and a question.
Yes.
So in our little break, I kind of looked up the specificity and sensitivity of ULTT for median.
Yeah, it's not that great.
Yeah. Well, actually, sensitivity seems pretty okay. So that's to rule out, right? But specificity is low. So like you said, it could help in like it can help in ruling out, but not rule in like a peripheral nerve pain.
And
the article is saying.
So they're saying like even if you get a negative test, it doesn't necessarily mean that there's no like issue with the nerve like mechanical movement. So specifically, they're not. Yeah.
Even if it has high sensitivity.
Correct.
Okay.
Because a lot of the tests they only target the large fibers. So it doesn't always. It's not always good enough to detect like nerve dysfunction. Yeah, so I guess like if you were to apply it like clinically, like okay, someone has numbness and tingling in like a certain area in their hand or whatever, and you're doing like a ULTT on them and you get negative, you should still treat it, because even if you get a negative, it doesn't mean that you can rule it out completely.
Okay.
Yeah.
And then my question was, you said they, even if it's like a central issue, like a central disease or something like that, treat the peripheral?
Yeah, so in the article, it talks about, so in central, I was talking more about central sensitization.
Oh, okay.
Correct. So, for example, someone may have like widespread hyperalgesia, altered like pain modulation, all those things. And so, like, if it seems like, okay, this sounds really like central sensitization, you should still treat the peripheral issues going on.
Was that like a suggestion, or did they do it and then they found like it you know, really
so in the article, it says that, yeah, I believe this is based off of, previous studies.
Oh, okay.
That the importance of treating the peripheral triggers, and it's crucial even when patients show signs of central contributions. Yeah, however, they said more research is required to evaluate the most effective treatment strategies. It seems like there hasn't been too many studies done on it before.
All right, cool.
I know you said something about the not using just light touch as a indication for.
Correct. Yes.
So the point of using temperature and pinprick, at least like from my understanding, was to look at different spinal pathways. But are you looking at also smaller fibers and larger fibers in that way? Because usually faster conduction through the smaller fibers, correct? Or no?
Correct.
So, or is it larger or smaller fibers? I think it's larger actually.
Larger.
And then, so with that, you're just, because it's a more sensitive measure, is that the purpose of using those instead?
Yes.
Okay.
Correct. To detect if there's actual like neurogenic like causes of their pain or whatever symptoms they have. Although honestly, like, I don't know how realistic it is to like incorporate it in just like your eval, or like it's kind of hard. Like, it takes some time, especially like hot cold stuff. But it's just something to think about if you are at a crossroads. But yeah,
I just had a comment on the talking about how, like, even if you get a negative test, you should still treat it. Because in my mind, like, how functional is like this position for people, and like if they're still getting like symptoms with other things, like that would give me more reason to keep testing something like that, because that's not like a functional position for them.
correct. So I think the main idea, so first of all, you would only use the ULTT if you already suspect like there's something going on. Like, you want to be intentional like in your eval. So I feel like there's already signs that are showing like, okay, there might be something neurogenic going on. For example, like if they get their pain when they're like screwing open a lid like this, or like something like that, like I would already suspect like, okay, maybe ulnar nerve is involved. And then you would do the ULTP. So I feel like in going into the test itself, you already have some suspicions. But if it doesn't give you that positive to really confirm it, I don't think it hurts to put them in that position and gradually like improve their neuromobility in that area that brings on their pain. So I would make it functional for them. So for example, if someone like gets a negative slump test but then later they tell you like most of the time that pain in their leg comes on only when they straighten their leg first and then they bend their neck forward, then like maybe you could check the slump test in the opposite direction. Like, instead of like slumping first and then doing the leg, you can do the leg first and then the slump part, and that actually has like been effective in treating. So I would say like make it functional for them based off of where you see that what brings on their pain in that region.
You're talking about treatment, right? Because yeah, not for diagnostic purposes.
Correct. This is for treatment for like neural involvement.
Cool. That was a nice discussion, guys. Any more questions for Rebecca? All right, Olivia, you are up.
Okay, so My paper is called the Concussion Symptom Cutoffs for Identification and Prognosis of Sports-Related Concussion. This came out of Pittsburgh University and actually was published in 2020, so super recent. Let me grab my notes. All right, so their intro kind of goes into the fact that reporting concussion symptoms are considered the most sensitive markers of concussion status. And this is actually according to the most recent International Concussion Consensus Statement. So this study was specifically looking at the post-concussion symptoms scale, which is the most commonly used, and it's 22 items where you're rating symptom severity from 0 to 6 with, like, as I said, 22 items. So it ranges from nausea, headaches, sleep, dizziness. I'll kind of go into that a little more later. And so kind of what we know right now is that some of the cognitive and mind grade cutoff scores can predict sports-related concussion. However, a lot of those studies are looking at patients that are coming in pretty early on once the injury occurs, but really most people aren't coming in. They average about 7 days after their injury, so pretty late. And so we know that time from concussion is a significant predictor of recovery time. So, you know, the sooner you go in to see somebody, the better. So currently there's not a lot of research looking into the role of time from injury on concussion symptom presentation cutoffs. So the purpose of this study was to evaluate that time. So they divided it into 2 groups. So it was either you got in before 7 days, like within that first 7 days, or you came in late. So like you went to see the doctor late, between 8 to 21 days, and how that can affect cutoff scores for total PCSS, which is that outcome measure, as well as the individual PCSS factors. And I'll describe kind of what those factors are as well. Yeah, I could really go on forever. I love this article. But so pretty much inclusion criteria, 13 to 25 years old. They got a total of 588 participants, and 319 were female. And so those had to be diagnosed with symptomatic sports-related concussion and coming into a specialty concussion clinic. Again, either 7 days or between that 8 and 21 days. Exclusion was any moderate to severe TBI, neurological disorder, or previous existing vestibular issues. So the PCSS factors included CMF, which is cognitive, migraine, and fatigue. There's also affective, which is the emotional aspects, sleep, which is just difficulty falling asleep or not sleeping regularly, and then those somatic issues such as nausea and vomiting. So the results. So in the early group, they had 79 with prolonged recovery. And so prolonged recovery was anything considered greater than 30 days. So having those symptoms for longer than 30 days. The late group, so those who came in late between 8 and 21 days, there was 106 with prolonged recovery. So kind of going into more of the important results. So pretty much overall what they found was that PCSS symptoms were more accurate, could more accurately differentiate athletes who had a concussion from controls, and they also predicted prolonged recovery. The factors, so some of those factors actually proved to be more predictive than just the total PCSS score, which is usually what is used. So specifically the CMF, the affective and sleep factors combined were much better. They were 98% accurate in the early group and 96% accurate in the late group. So kind of overall, like, I think what makes this article super important is that with concussion assessment and management, we're so reliant on subjective symptoms, that if we can find a better way to kind of guide our treatment as well as predict maybe who is more likely to have those prolonged factors, we can adjust and tailor our treatment management better. So again, like maybe you're looking at some more of those affective aspects. So, you know, maybe they do need to see you need to refer out for some type of psychologist. Or like those sleep factors, right? I mean, we're not always looking at that as physical therapists, but it should definitely be considered, especially since they're so predictive. Super interesting article. There's like a million other like results that they found. So I highly recommend, if you're interested, to give it a read.
Awesome. Any questions? Thanks for joining, Jamie.
Hi, Jamie.
Amy, you have like a gamer's headphone on. I was like, whoa.
Any questions for Olivia?
Yeah, I think I don't know if I missed it, but what was the control group?
So the control group was, because I missed that in the first time, it's just healthy controls that were just matched based on age and demographics.
So they didn't have any injury or anything, and
yeah, no
they had no symptoms, or like
no. So they just had no concussions, and they filled out the PCSS because a lot of that too is just like you could have a headache in general, or all the time, or you could have there's actually like maybe I'm thinking of the SCAT5. I might be thinking of the SCAT5 anyway. But there's like some like numbers that are within norm of just the general population to compare to. Yeah.
Okay. So, and then the experimental group had, and when they filled it out, they had more of these like headaches or whatever, and whatever the PCSS.
Yeah. The cutoff, the total cutoff score is greater than or equal to 7.
Okay.
And that's just like, that's the agreement from a plethora of other studies too.
And then you said they divided the groups to the people that came in early and then the people that came in late, right? There's 2 questions for that. Like, what was the purpose of doing that? And then when they did it, I imagine the numbers would be like the participants in each group would be different because, you know, I mean, I would think like more people would try to come in early. So
you would think, yeah, Taylor, they don't. Yeah, it's not unless you are like in a D1 collegiate kind of sport, or I mean, high schoolers think like they have games on whatever. They're not gonna come and see you maybe until Monday, but most people don't come in really soon.
But the groups were different in the number of people that were in each group.
Yes. So yeah, but there was no difference between, so there was in the early group, so the controls, there was 44 of them. In the early group, there was 348, and in the late group, there was 240.
Okay.
But there was no significant difference in any of like the demographics. The only thing difference between the early and the late group compared to the controls was actually those people had a history of concussion and a history of migraine and a higher incidence of ADHD and learning disability, which kind of, I mean, that in itself kind of says a lot, right? I don't know if I answered your question.
Statistical power wise, it might, that might affect the, statistics because the groups have different numbers of participants.
Right. Yeah. I agree, especially with controls being only 44. Yeah. But I also think that the fact that the groups are so large helps with some of that stuff.
Yeah, that would definitely help. But yeah. Okay.
So at least from my experience in concussion clinic, so when I was at Chalk, the average time to come into clinic was about 30 plus days. And so between concussion, getting to the doctor, being referred to the doctor to Chalk, it was about 30 days. And usually so we would have a bunch come on the schedule, but eventually a lot of them would cancel because they were like, oh, you know, my symptoms have gotten better. But then usually the ones who are 30 plus days out, they're really severe. They have really severe deconditioning. Their cardiovascular system and their hormones are out of whack. They're tall. It's crazy. So, and then, but also most concussions do not occur in sports settings. They're a result of accidents, being hit in the head with something, or a car accident. And I'm actually at a concussion clinic for my job, and what they're now trying to do is we're going to local hospitals and we're setting up concussion clinics because we're trying to get more people to recognize the symptoms, so that way we get earlier diagnosis. So that's kind of what we're doing.
What was the reason for them not coming in? They just didn't think they had a problem?
Yeah, so I mean, a lot of ERs will not diagnose concussion. I had a concussion when I was playing soccer. They did not diagnose it at all. They thought it was, oh, her spine's clear, her imaging is good, bye. Like, they never even considered it. And lots of places do that. So it's not high on the priority list.
And I think most people don't know that they should be going in to see people. And also a majority of concussions resolve on their own. But the problematic ones, like Taylor said, are the ones that last for, you know, me, I had 2 concussions. All my symptoms lasted for 2 months. My second one lasted for 2 years. But like, I didn't get any management for that. So if we can get them in early, and recognize those who are more like higher predicted to have those like progressive, like long-term issues, if we can get them in early, we lower that chance of having symptoms past 21 days.
And look at you, y'all are doctors. Almost there. Don't worry, you're right there. You're on the cuff, Olivia. You're on the cuff.
So close.
Awesome. Any more questions for Olivia? Cool. Awesome article. I'm up, I guess. I kind of did research on something I pretty much knew, but I went for it anyways. It's about KT taping of the ankles and how effective it is, or is it effective for proprioceptive control in soccer players? I know I have a couple soccer players in here. It's pretty common to have an ankle sprain or ankle injury. They just call it an ankle injury. It doesn't specify what type of ankle injury. They just want to measure proprioception in general. This was done in 2016. So let me get my notes. The purpose of this study was to establish if it was possible to improve soccer players' proprioception via bilateral application of KT tape to their ankles. And what they did was just put KT tape medial laterally and pretty much from the plantar aspect of the foot all the way down, all the way up to their soleus. So they had 2 planes technically, like the sagittal plane and a frontal plane. They didn't really have a transverse plane to work with. But the proprioceptive ability assessed during proprioceptive ability assessed using balance and fine motor control tasks. It was pretty much like similar to that SOT thing that Dr. DeMars has. It was the forced place to assess the accuracy of the patient's center of balance or the center of pressure. So what they had was they used that to measure postural sway, small foot, and ankle movements. They had like different targets to hit. So you were the X and you had to go hit the 0, and you kind of just did an ankle sway because most postural sway comes from the ankles and the foot. And postural sway pretty much can suck it's a lot due to either instability or peroneal muscle activity, which is decreased. And when this happens, you most likely get an ankle sprain or ankle injury. So overall, they found no difference through taped trial and non-taped. The taped actually had like 4 more points, which I forgot how many points it was out of, but it was not significantly different. And reducing injury of risk through KT tape isn't supported by this study. And I thought about this a little bit, and since proprioception mostly comes from muscle spindles, through muscle lengthening and Golgi tendon organs, right? And those are in tendons and muscles. It's not superficial. So I was thinking, yeah, why would KT tape help you with your proprioception? It's kind of just a very psychological way that you feel like it might help you, which is cool. If it helps you psychologically, especially for higher end athletes, if it feels like it helps them and they do well, go with it. I guess it's their time and money, but we can always educate patients like, oh, that's not really going to help. Like we learned through school and Dr. Bennick, like taping kicks ass. If you have instability, right? If you have instability, not proprioception. But it does, what was it? It decreases 1% of performance or some shit like that. So that might not work with higher end athletes if they're looking for mobility instead of stability, because some people need more mobility. But yeah, KT tape for the ankle, at least in my article, was a no-go, or didn't support increasing proprioception. All right, any questions for Kaz?
Yeah, I think kind of because did they have any like subjective questions about like to measure like, oh, like did they feel better wearing it? Did they feel like they did better? Because I feel like that would be such a important like aspect if that's what the studies have been showing. You think that would add maybe just like
That would be pretty cool if they these people in the UK don't care about their what they think. I guess it was just, I mean, it was a pretty low end study regardless. It was just another study to see if it helped or not for soccer players. But yeah, you bring a good point. It would help out if kind of they felt better.
I think even if the study found like a difference, it doesn't have good validity because it seems like what they measured was all static stuff, right?
They had perturbation through, they had like an internal perturbation, right? You had to follow pretty much the dot. So I would be standing and I'll be doing like this kind of thing.
That's
very soccer-like.
If you're an athlete, your injuries, from, I don't know, like running or jumping, So
I agree.
yeah, I don't think KT tape's that effective anyway.
Good point, Andrew.
Okay, cool.
Cool. Are we wrapping this up? I'll just end the recording here. Sounds good?
Yeah, so one comment on the taping thing.
Yeah.
So I don't know if you guys have looked at so there's a couple studies that look at how long taping lasts, and between body heat and the movement, they usually only last less than 20 minutes. So by the time they get through their warm up, it's basically garbage. So like, I mean, definitely, I think it's more for the psych effect. If it works for them, go for it. If not, just put on a regular ankle brace. You save money and time.
I like that. I do wear ankle brace every once in a while.
And then also in regard to like, I guess the KT tape and like the subjective reports, it's like, I guess to some degree, it's like if it's research based, like why does it really matter? Because it's like you're not really getting that objective measure that like is gonna really say like, oh, this is, I mean, we're really looking at, is it effective or is it not? We're not really looking at the psychological aspect of it. Because I feel like one of my mentors that I like really like I talked to about like ACLs and stuff, like he's super big on that. He's just like so against like the use of like KT tape and stuff, just because of like it just has very like little effectiveness. And he's even against like, how we were just talking about like, oh, if people feel good wearing it and it makes them feel better, like go ahead. And he's just like so against like just like, no, it has no effect, like don't use it. So it's just like interesting to see like, are we just doing it because we want like, it's like the placebo, it's like ultrasound, like are we actually using ultrasound? Are we really like, what's the point? Like I don't know, like for me personally, I feel like I would just do it just because, okay, whatever, like it makes them feel better, I don't really care. But like, it's like, are we really doing ourselves a disservice, by doing it and continuing these kinds of like practices, I guess, like as physical therapists, and like with us trying to progress like the field and everything.
I mean, I used KT tape on patients before because they wanted it. But I don't know, what do you guys think? Like, do you think we should educate patients on the research? Like, if patients want it, do you think we should tell them, oh, you know, it's not that effective, so don't do it? Or like, just, you know, if they want it, just give it to, I don't know. What do you guys think?
I mean, sometimes our jobs are determined by patient outcomes and if your patient's happy with you. So if your patient is not happy with that tape, to a certain degree, I would say tape them. But if it gets to a point where it's an obsession and they won't do anything without the damn tape, then no.
I mean, placebo's real.
I feel,
That's a real
Yeah.
thing.
Yeah.
Yeah, I agree. I'm with
I
them.
feel like, yeah.
I usually have tape available and I'll ask them, but it depends on your relationship with the patient too. Because some patients I could be like, bro, that's not gonna help you like at all. Like I could say that to some patients and they'll be okay with it. They'll be like, oh, whatever, ha ha ha. But like some patients like, I need the KT tape, and they'll tell me with like a straight face, and I'll be like, all right, you got it. What color you want? You know what I'm saying? Yeah. All right. Cool. Let me just stop this recording.